Good morning all. I'm Dr. Haripriya C. Today I will be leading the discussion for our reading club, section 8 on Misch contemporary implant dentistry, which is being conducted in connection with the International Implant Summit 2026.
Chapter 41 Perimucositis and Periimplantitis Diagnosis, Classification, Etiologies and Therapies. An understanding of the mucoepithelial implant attachment is essential before commencing maintenance procedure. Controversies and parameters for probing and crestal bone loss are important for clinicians to recognize. There are anatomic and histologic differences between the attachment apparatus of teeth compared with implants that are osseointegrated. The bacterial plaque biofilm on these implant tissue attachments may be significant to clinical success. Patients need to recognize the importance of maintenance protocols, and clinicians should assess compliance to home care routines. Patients also should become competent to perform home maintenance. These strategies would certainly minimize risk of peri-implant disease and implant failures. With the increase in the number of dental implants being placed each year, a resultant increase in the incidence of peri-implant disease has been seen. Two conditions of peri-implant diseases are peri-implant mucositis and peri-implantitis. The 6th European Workshop on Periodontology in 2008 concluded that peri-implant diseases are infectious in nature and are defined by changes in the level of crestal bone, presence of bleeding on probing or suppuration, with or without deepening of the peri-implant pockets. In differentiation between these two peri-implant conditions, both have been shown to be localized around implants and demonstrate features similar to adult chronic periodontal disease. These conditions may be analogous to gingivitis, that is perimucositis, and periodontitis, peri-implantitis. The bacteria responsible for gingivitis around a tooth may affect the epithelial attachment without loss of connective tissue attachment. Because the connective tissue attachment of a tooth extends an average of 1.07 mm between the crestal bone, at least 1 mm of protective barrier above the bone is present. In contrast, no connective tissue attachment zone exists around an implant because there is an absence of connective fibers that extend into the implant surface. Therefore, no connective tissue barrier exists to protect the crestal bone around an implant. In summary, periodontal disease that develops around dental implants has been classified into two separate entities, peri-implant mucositis and peri-implantitis. Peri-implant mucositis is defined as a reversible inflammatory reaction in the peri-implant tissues surrounding an implant. Peri-implantitis is defined as an inflammatory reaction with loss of supporting bone around an implant. Although it is impossible to guarantee 100% sterility of exposed implant surfaces, the body is capable of removing small amount of bacterial deposit via host defense mechanisms. Carefully removing macro deposits of plaque biofilm and irrigating with antimicrobial solution is generally sufficient to allow a favorable environment for new attachment formation. It is recommended that patients complete a full mouth debridement to reduce bacterial colonies, including plaque biofilms on exposed implant surfaces. Peri-implant mucositis. Peri-implant mucositis is an inflammatory condition of the soft tissue surrounding an implant which is similar to gingivitis around natural teeth. The bacteria and etiology of peri-implant mucositis are bacterias Provertella intermedia, Porphyromonas gingivalis, Agrigabacter actinomycetic competens, Tendrella forsythia, Treponema denticola, Provertella nigrans, Fusobacterium nucleatum, and the etiologies are poor oral hygiene, poor compliance with supportive procedures, poor prosthesis design, poor fit of prosthesis, non-ideal implant position, lack of non-keratinized peri-implant mucosa, and retained cement. Management: non-surgical or close debridement, mechanical debridement to remove plaque and calculus from the implant surface using mechanical instruments such as scalers and curettes coupled with antimicrobial rinse therapies is the primary therapeutic approach for peri-implant mucositis.
It is crucial to implement a comprehensive patient and professional oral hygiene program to manage peri-implant mucositis. Power brushes, interproximal and irrigation power devices, dentrifiers, and antimicrobials have been shown to be highly effective in the management of peri-implant mucositis. Professional mechanical debridement. Curettes. Titanium coated curettes are specifically made for dental implant debridement because they have a similar hardness to the titanium surface and will not scratch the surface. Carbon fiber curettes are softer than the implant surfaces and will not damage the implant surface. These types of curettes are prone to fracture. Teflon curettes are similar to carbon reinforced curettes and will not scratch the surface of the implant. Plastic curettes have been advocated as the instrument of choice to prevent damage from the implant surface. Stainless steel curettes are much harder than titanium alloy and are not recommended for use around dental implants because they may alter the implant surface. Amorphous resin scalers come with unfilled or filled resin. Unfilled resin scalers have no reinforcement for shape or stiffness, whereas filled resin fillers may use materials such as silica, graphite, or glass. These scalers have replacement tips on stainless steel hardness. Titanium brush burrs insert into the implant mortars and they have a variety of shapes allowing them to adapt around the implant or prosthesis surface circumferentially around a single surface and for groove cleaning. Brushes are used at 600 rpm and adapted against the implant surface to remove debris. Hastruck et al. Evaluated 6 different types of scalar materials to scratch surfaces of different brands of implant abutments and they were compared with scanning electron microscopy. The results showed glass-filled resin curettes caused the most scratches whereas the unfilled resin scalars had the least surface alteration. However, these studies are on smooth titanium abutments and not on the rough implant surface. There may not be clinical relevance regarding whether curettes scratch implant surfaces. Anastasiadis et al. Reported that metal scalars do not readily scratch cementum. It is questionable that a titanium implant surface which has a higher Mohs hardness should be of any concern. Furthermore, scalars as a whole may be effective in removing large calculus particles or granulation tissues, but rather ultrasonic devices. Ultrasonic devices with special polyether ether ketone coated tips have been used to debride the implant surface. This tip is made of a plastic material with a stainless steel core. The debridement of plaque and calculus while leaving a smooth and clean surface. Although metal tips are not recommended, plastic tips may be at an increased risk of shredding when cleaning around implant grooves and threads. Antimicrobials. Chlorhexidine applied on a cotton pellet and burnished against a machine surface has shown a 92.9% Porphyromonas gingivalis endotoxin reduction. Povidone iodine has high antiseptic capability but has a highly irritating effect if any residue comes in contact with an osseous structure. Peri-implantitis. The American Academy of Periodontology has defined peri-implantitis as an inflammatory reaction associated with the loss of supporting bone beyond initial biologic bone remodeling around an implant in function. The clinical symptoms associated with peri-implantitis are vertical bone loss, that is on radiograph, probing or both, peri-implant pockets, bleeding on probing, exudate, mucosal swelling, erythema, and usually no associated pain. Etiology. Biofilm. Although bacterial biofilm insult is identified as the main cause of peri-implant mucositis, peri-implantitis, and is considered to be initiated by stress factors caused by poor biomechanical forces. In addition, several other etiologic factors exist, such as poor implant placement, poor oral hygiene, residual cement, host response, poor implant surface, unfavorable osseous density, untreated periodontitis, alcohol excess, smoking, untreated endodontic lesions, diabetes, among others. Occlusal stress. In recent studies, bacterial biofilms attached onto the surface of implants were shown to create a highly acidic environment that causes corrosion, pitting, cracking, etc. Furthermore, recent studies have shed light on the release of titanium ions from the implant surface, which results in a significant increase in a local inflammatory response. History of periodontitis. Most long-term studies and systematic reviews have concluded that patients with a history of periodontitis had a higher incidence of peri-implantitis in comparison with periodontally healthy patients. Smoking or tobacco use. The overall peri-implantitis rate in the study population was 11.2% and as high as 53% for patients who smoked and had a history of periodontitis. Diabetes. The relationship between diabetes and periodontal disease is well established. Poorly controlled diabetes has also been associated with peri-implantitis. Venza et al. Reported that the long-term prognosis for dental implants is more favorable when patients' glycosylated hemoglobin, that is HbA1c, is less than 7%. Lasers. One of the newer and least invasive methodologies to treat peri-implant mucositis and peri-implantitis involves the use of laser photonic energy, a coherent form of infrared or visible light, usually of a single wavelength. Lasers have been used effectively for decades in oral implantology in second stage recovery of implants through the ablation and vaporization of overlying soft tissue. Laser protocols. Similar to their use in treating periodontal disease, lasers provide different treatment approaches for peri-implantitis: non-surgical, surgical, antimicrobial photodynamic therapy, and photobiomodulation. Non-surgical. In the non-surgical modality, lasers are used adjunctively to help remove calculus, reduce inflammation, and remove diseased soft tissue and reduce subgingival pathogens. Using different types of lasers such as the diode NdYAG, that is neodymium doped yttrium aluminum garnet, erbium or carbon dioxide laser, the laser beam is directed at the inflamed soft tissue within the sulcus using non-contact overlapping stalks to disrupt the film, reduce the microbial population and decontaminate the pocket epithelium. Erbium lasers have also been shown to remove calculus from the implant surface. Surgical. Minimally invasive laser-assisted surgical techniques involve removal of diseased epithelial lining. More invasive surgical procedures involve conventional elevation of a full thickness flap for surgical access followed by laser-assisted degranulation, surface debridement and decontamination, and osseous tissue removal or recontouring. As indicated, bone augmentation may be performed through placement of bone grafting material.
Antimicrobial photodynamic therapy. Antimicrobial photodynamic therapy in periodontology is a light-based approach to terminating bacteria. A photoactivatable substance, that is photosensitizer, is applied to the target area, that is within the sulcus, and then activated by laser light. Singlet oxygen and other cytotoxic reactive agents are produced to reduce periodontopathogens.
Photobiomodulation. It is a form of light therapy that uses non-ionizing forms of light including lasers in the visible and infrared spectrum. The non-thermal technique is used to elicit photophysical and photochemical events. In implantology, it is used to promote wound healing and tissue regeneration. It has also been shown to increase osteoblastic proliferation, collagen deposition, and bone neoformation. Surgical management of peri-implantitis. Surgical management is completed with curettes, specialized titanium brushes with an implant handpiece and or a glycine polishing handpiece. Along with mechanical decontamination, a chemical decontamination process should be followed using compounds such as doxycycline or tetracycline or citric acid. The flaps are then approximated in their original position using horizontal matrix sutures which adapt tissue around the implant while creating a ferrule effect. Interrupted suture will also serve this purpose. Regenerative procedures. The regenerative technique. First, the circular incision is made around the clinical site with one tooth mesial and one tooth distal. Second, full thickness mucoperiosteal flap is reflected past the mucogingival junction to ensure enough tension release from flap tissue. It is essential to produce adequate release so there is minimal tension when closing the flap. Inadequate reflection will result in incision line opening, which will increase mobility of the graft. The bone surface is curated to clean and remove all soft tissue remnants. Bone surface is curated, being careful to remove all remnants of soft tissue. Detoxification. Tetracycline paste, EDTA or citric acid applied to the exposed surface for 30 to 60 seconds and rinse with sterile saline for 30 seconds. A full thickness flap is reflected to gain adequate access to the defect and implant threads. Thorough removal of granulation tissue is critical. Bone graft of choice, that is ideally an autograft or allograft, is placed on the defect. A resorbable membrane is then draped over bone graft, being careful to cover 3 mm past all edges of bone graft. Tissue tension is reduced via tissue stretching techniques. Flaps are then sutured, that is with high tensile strength suture material, that is polyglycolic acid sutures 4.0, and being careful to provide tension-free closure to produce maximal contact between tissue edges. Apically repositioned surgical technique. This surgical technique is used for implants that have generalized horizontal bone loss greater than 1 to 2 threads. Platelet concentrate growth factors. In implant dentistry, the two most common platelet concentrates are termed under general acronyms of PRP, that is platelet-rich plasma, or PRF, platelet-rich fibrin. These products are often considered growth factors and used in regenerative medicines. Although protocols vary, most platelet concentrates are blood extracts from a whole blood sample that is processed via centrifugation. The processing technique separates the blood components into usable, example fibrinogen or fibrin, platelets, growth factors, and leukocytes liquids in plasma, or unusable forms, that is red blood cells. The use of platelet concentrate, example PRP and PRF, for treatment of peri-implant defects has been widely researched with varying results. Unfortunately, the literature on this topic is controversial and conclusions are extremely variable. Platelet-rich plasma or PRP with and without bone substitute has been studied with the treatment of peri-implant defects.
In various dog research models, most researchers have not found beneficial results with PRP alone, in combination with xenograft bone and with guided bone regeneration procedures. Suzuki-Resnick peri-implant disease protocol. Protocol number 1. Less than 3 mm probing depth, no plaque, no bleeding on probing. Treatment: maintain regular home care, 3 to 6 month hygiene recall. Protocol number 2. Peri-implant mucositis. Less than 3 mm probing depth, plaque presence and bleeding on probing, or 3 to 5 mm probing depth, plaque presence or bleeding on probing. Treatment: follow treatment regimen A, increase hygiene recall frequency, that is approximately 3 months, increase home care education. If no resolution, proceed to protocol number 3. Protocol number 3, peri-implantitis. 5 mm probing depth, plaque presence, bleeding on probing, crestal bone loss more than 2 mm. Treatment: follow treatment regimen A, B, C and D, increase hygiene recall frequency approximately 3 months and increase home care education. Protocol number 4, implant mobility pain upon function bone loss greater than 50% of implant length and uncontrolled exudate. Treatment: follow treatment regimen E. Peri-implant disease treatment regimen. Treatment regimen A, mechanical close debridement or acceptable instrumentation. Resin, titanium, graphite, carbon fiber and gold-tipped instruments can be used to remove deposits. Prophy cup or brush, air polisher with glycine powder, Profijet, Savitron. And treatment: chlorhexidine 0.12% or 0.2% or cetyl pyridinium chloride. Check for occlusion. Treatment regimen B, antiseptic therapy. Subgingival antiseptic irrigation. 0.12% or 0.2% chlorhexidine is added to the mechanical therapy.
Irrigate intraclavicularly to disrupt and dislodge the biofilm, then thoroughly debride the implant surface with a curette. Irrigate a second time to rinse out the debris and further detoxify the subgingival area. Pressure is then applied for 1 minute to obtain intimate soft tissue or restoration contact. Alternative antiseptic diluted sodium hypochlorite diluted 0.25% hypochlorite solution is equal to 1 teaspoon, that is 5 ml of standard 6% household bleach or Clorox, and diluting it ounce or 125 ml of water. Check occlusion, possible occlusal guard.
Treatment regimen C. Antibiotics. Add systemic or local antibiotic treatment. Systemic amoxicillin, metronidazole 500 mg or 3 times daily for 8 days. An alternative clindamycin, augmentin, tetracycline, bacitrip, ciprofloxacin. Local tetracycline. Alternative doxycycline, minocycline spheres or Arastin.
Treatment regimen D. Surgery. Assess open debridement, bone graft and closure. Step 1. Assess flap, open debridement with hand instrument, implantoplasty. And step 2. Detoxify with apply 0.12% or 0.2% chlorhexidine with cotton pellet for 60 seconds and rinse with saline. Apply 20 to 40% citric acid with cotton pellet or spatula or titanium brushes for 60 seconds and rinse with saline, or apply tetracycline paste with titanium brushes for 60 seconds. Other detoxification agent are EDTA, hydrogen peroxide, 0.25% hypochlorite, erbium YAG laser, that is diode laser alone result in an unacceptable increase in implant body temperature. 3. Bone graft with mineralized or demineralized, that is 70 by 30 plus autograft if indicated. 4. Cross-linked collagen. Step 5. Tension-free closure with vicryl or PTFE sutures. Treatment regimen E. Implant removal. Tissues. Many clinicians consider keratinized attached gingiva important to maintaining gingival health. Mucogingival considerations in restorative dentistry have been considered. They concluded that if subgingival restorations were to be placed in areas of minimal keratinized gingiva with less than optimal plaque control, augmentation to widen the zone of keratinized tissue may be warranted. Management of lack of keratinized tissue. Several surgical techniques to increase the amount of keratinized tissue around dental implants have been described in the literature. First, autogenous free gingival graft. Second, autogenous subepithelial connective tissue graft. Third, allogenic soft tissue graft from human cadavers. 4. Synogenic soft tissue graft from animals. And augmentation can be completed before surgery, concurrent with surgery, or after implant surgery. The most ideal time to graft is before surgery. Retained cement peri-implant disease. Cemented implant prostheses are used in implant dentistry because of the lower cost, relative simplicity, more passive fit, improved aesthetics, and similarity to traditional prosthetics. However, with all of these advantages, significant disadvantage: the retention of post-operative cement. The retained cement has been shown to harbor bacteria similar to calculus with a natural tooth, which leads to peri-implant disease. The problem of excess cement has been associated with greater than 80% of cases of peri-implant disease. No particular difference or correlation could be associated with the type of cement used to lead the restoration in regard to either the presence of disease or treatment response. That is, when comparing resin cement, resin modified glass ionomer, zinc polycarboxylate, and glass ionomer. Implant quality scale. The criteria for success in implant dentistry remain complex. Most clinical studies reporting success and failure do not qualify the type of success achieved. Instead, the term success primarily has been used interchangeably with survival of the implant. The term failure has been used to indicate the implant is no longer present in the mouth. Nearly all reports in the prosthetic literature also report survival as success. Now, this is a tabular column of implant quality scale with implant quality scale, clinical condition, and Suzuki-Resnick protocol. In implant quality scale, first success or optimum health, with osseointegration or stage 0 osseoseparation. Clinical conditions are no pain or tenderness upon function, zero mobility, less than 2 mm radiographic bone loss from initial surgery, probing depth less than 4 mm, no separation or no bleeding on probing. The Suzuki-Resnick protocol is protocol number 1. Second, survival or satisfactory health with stage 1 osseoseparation and perimucositis. Clinical conditions are no pain, zero mobility, less than 2 mm radiographic bone loss from initial surgery, perimucosal inflammation, probing depth plus or minus 4 mm. Then protocol number 2. Third, survival or potentially compromised. Stage 2 osseoseparation, early peri-implantitis. Clinical conditions, no pain, zero mobility, 2 to 4 mm radiographic bone loss, probing depth plus or minus 4 mm, perimucosal inflammation and bone loss less than 25% of the implant length. Protocol number 2 or protocol number 3 has to be followed. 6. Survival, compromised health, stage 3 osseoseparation or moderate peri-implantitis. Clinical condition, variable pain, zero mobility, perimucosal inflammation, probing depth more than or equal to 6 mm, bone loss 25 to 50% of the implant length. Protocol number 3. Stage 5, failure, clinical failure. That is stage 4 osseoseparation, advanced peri-implantitis. Clinical features, perimucosal inflammation, pain upon function, probing depth more than 8 mm, bone loss more than 50% of the implant length, mobility, uncontrolled exudate may be no longer in the mouth. So protocol number 4. And stage 6, others such as retrograde peri-implantitis, variable perimucosal inflammation, radiographically periapical lesion around the implant, clinical pain, tenderness, fistula formation or swelling, surgical re-entry and revision or removal of implant. The American Dental Association (CDT) in 2018 has defined 5 periodontal types of diagnosis and treatment of natural teeth. The American Dental Association's categories of disease do not simply indicate success or failure but rather a range from health to disease. This classification allows a clinical approach to treatment in each category. A similar scale for implants has been established as an aid to diagnosis and treatment that also proposes management approaches according to the signs and symptoms. They are Group 1 optimum health, Group 2 satisfactory health, Group 3 compromised survival and Group 4 clinical failure. Now moving on to next chapter, chapter number 42, implant maintenance, long-term implant success. Tooth versus implant movement. A natural tooth exhibits normal physiologic movements in vertical, horizontal and rotational directions. The amount of movement of a natural tooth is related to its surface area and root design. Therefore, the number and length of the roots, their diameter, shape and position, and the health of periodontal ligament primarily influence a tooth's mobility. A healthy tooth normally exhibits zero clinical mobility in a vertical direction.
Studies have shown the actual initial vertical tooth movement to be approximately 28 micrometer and is the same for anterior and posterior teeth. The vertical movement of a rigid implant that is integrated has been measured as 2 to 3 micrometer under 10-pound force and is due mostly to the viscoelastic properties of the underlying bone, that is bone density at the bone implant interface.
Moving on to the conclusion, the ongoing maintenance of dental implants is one of the most important factors for long-term health. With increasing numbers of implants being placed each year, it is evident that the prevention of peri-implant disease is paramount to success. An individualized implant maintenance program needs to be implemented that is tailored to the specific patient, the implants and the prosthesis. Successful implant maintenance depends on many factors, most importantly communication and collaboration between the dental professional and the patient. Peri-implant disease is a prevalent disease. Therefore, a comprehensive maintenance program is essential to decrease complications. The implant clinician must understand the factors and the need for a systemic maintenance protocol, along with informing his or her patients of the most updated information to ensure longevity of their implants and prostheses. Hereby, I conclude the session. Thank you.